Hello, everyone, and thank you for coming to watch our research presentation. For the past year, our team has been working on comparing traumatic brain injury survivors' functional outcomes after participating in traditional occupational therapy and computer-based therapy. Dr. Douglas Rakowski is our primary investigator. Our research advisors are Dr. Noha Daher and Dr. Dragana Kropalik. Our research team comprises of Bergen Benedict, Kevin Butler, Gino Claudio, John Din, Joshua Lee, and Jonah Martinez. The following slide will be showing visuals and sounds representing a realistic motor vehicle accident traumatic situation. So if you've ever experienced anything similar to this, we ask that you take caution and may want to lower your volume or look away. This is the evaluation note of an actual patient within our research. Patient with no past medical history presented at hospital, status post motor vehicle accident, rollover as rear passenger, unknown seatbelt at freeway speeds, positive sign for loss of consciousness. Patient was found under another person and was extricated from the car. GCS was 8 on arrival to the hospital emergency department. And on examination, patient showed 8 centimeters, frontal scalp laceration, full thickness right knee lacerations, swelling and abrasions on left ankle, and bruising on left chest. Patient was intubated for airway protection. CT head showed left-sided scalp soft tissue laceration with subcutaneous air and right parietal subarachnoid hemorrhage. While there was more to report on this patient, we wanted to highlight these details as it pertains to the condition we are focusing on, traumatic brain injury, or TBI. Did you know that in 2019, there were 233,135 TBI-related hospitalizations and about 69,473 TBI-related deaths in 2021? TBIs can affect the brain by inflicting a bump, blow, jolt, or penetrating energy to the head. And depending on the severity and type of TBI listed here, mild, moderate, severe, TBIs may range in physical symptoms such as fatigue, loss of coordination, persistent headaches, sensory symptoms such as sensitivity to light or sound, changes in taste, or being in a coma, and cognitive symptoms such as emotional changes, amnesia, or profound confusion. And so due to the many complications that may arise from a TBI, therapy is primarily focused on improving physical functioning while incorporating emotional and social interventions in the process. And so traditional occupational therapy, or OT, utilizes a holistic approach and a variety of interventions to develop, recover, or maintain fundamental living skills, such as working on motor abilities, addressing visual processing abilities, increasing cognitive functioning, etc., as shown on the left picture here. Computer-based therapy, CT, is simple and convenient to use in many settings and offers a wide range of engaging and interactive games to help improve coordination, strength, and cognition, shown in the right picture. An OT approach utilizing therapeutic use of technology has the potential to provide opportunities for mass repetition within a dynamic hybrid virtual environment to build upon various performance skills needed to improve functioning.
So the purpose of our study was to determine the functional outcomes and added improvements occupational therapy practitioners can attain when integrating computer-based therapy, or CT, into their intervention plan for individuals impacted with the TBI. For our study, we utilized a retrospective medical record review design to compare the functional outcomes of different therapeutic intervention approaches. For those who do not know what this type of study design is, a retrospective design is the outcomes of interest that have already occurred in each individual by the time he or she is enrolled in a study. The data that is collected is either from the records, from previous records, or by asking the participants to recall exposures. For our research study, we took previous medical records to gain for our participants. The functional outcomes were organized and analyzed based on patients who have received only traditional occupational therapy versus a combination of traditional occupational therapy and computer-based therapy. This study reviewed data such as patients' length of stay, GG codes, and pain scale from medical charts ranging from June 2019 to June 2022.
For our inclusion and exclusion criteria for our participants, we looked for individuals aged 18 to 89. We included all ethnic individuals of both genders. They had to have been diagnosed with a traumatic brain injury. And as previously stated, they had to have been charted for dates of June 2019 to June 2022. And they had to have been discharged. For our exclusion criteria, they must not have been classified as a Rential level 1 to 3, cannot have left against medical advice, and could not have been diagnosed as a non-traumatic brain injury. A non-traumatic brain injury could include anoxic, which means they don't have enough oxygen to the brain, have a brain tumor, have cancer, non-cancerous, or craniotomy during the time of their visit.
So the following data is from the patient medical records, which we collected, reviewed, and extracted onto an Excel spreadsheet for analysis. So from the bullet points listed below, these were all the bullet points we had on our data extraction form, which was on Excel, including a medical record number. My fellow researchers may say MRN numbers, which is the same thing. Treatment received, either OT or the combination of OT and CT, age, gender, admission date, number of CT sessions, and GG codes, which is the most important in our research, is what we looked at. And a GG score or code is a standardized assessment utilized by Centers of Medicare and Medicaid Services to measure the patient's need for assistance across 9 self-care categories, these including eating, oral hygiene, toilet hygiene, bathing, upper body dressing, lower body dressing, and donning and doffing footwear, and other mobility activities at discharge and at admission. And these levels range in assistance level from 1 as being dependent to 6 as being independent.
Next, we'll be discussing our procedures, and we've made an easy to follow map of pictures here so you can follow along. We first went to East Campus, generally in groups of 2, to meet with Dr. Rakowski to access the East Campus medical database. We then collected nearly 800 medical record numbers, and then we identified whether or not they met our inclusion or exclusion criteria previously listed in slide 8. Next, we extracted the appropriate information listed in the previous slide and documented it into Excel. Once we gathered enough participants and we input our data into SPSS to be analyzed, we then used a random number generator to select 5 random participants for our qualitative data.
And so, like John stated earlier, all of our data was analyzed using SPSS with categories of general characteristics of our patients, pre and post GG scores, as well as number of CT sessions. And so some of the tests we used in SPSS were descriptive analysis, which are just basically basic means, ranges, and standard deviations. We also used Wilcoxon sign rank tests, which was used to compare 2 paired samples to determine the significance between them. We also used this cousin Mann-Whitney U test to compare 2 independent samples to determine the significance between them. And as we can see to the right, table 1 shows our general characteristics of our population. And here we can see that our mean age was 41. And this was with our range being from 18-year-old to 84 years old. And one thing that was interesting was that a majority of our population, around 80%, were male, as it coincided with that literature review. We also found that length of stay was around 4 days shorter for group 1 by around 4 days. Although we don't know if this was due to the effects of different treatment styles or other compounding factors. And so when assessing our population and the efficiency of both treatments, we looked at the GG scores from both evaluation and discharge of pre-post scores. To get a more micro picture, we also had recorded data on each specific domain of ADLs. When we look within the 2 groups, or the first 2 columns, we can see that both treatments are significant. This means that both treatments are actually doing what they're intending to do, and we can assume that these results did not happen by statistical chance. Rather, we can put confidence in that both treatments, OT or OT and CT, help the patients improve in each domain. When diving into the specifics, we can also see that both group 1 and 2 had some phenomenal changes in all the categories, with it averaging around 2-point increase in functionality. This is amazing, as this can be interpreted as many patients coming into the hospital averaging max mod since, and being discharged as setup, cleanup, or supervision assistance. Across all domains, we can also see that total GG scores changed by around 15 points, which is huge when it encompasses overall functional gain. And finally, when we look at the last column, we're measuring between groups or comparing them against each other. When doing this analysis, we found it to be insignificant for both total change and in each specific domains. Therefore, we cannot say one group is better than the other, and we have to look at these results with a grain of salt.
To compare the qualitative data between traditional OT and computer therapy sessions, we randomly selected 5 charts from each category and summarized those findings. As I go into further detail, my 2 colleagues on the left will be demonstrating a typical session for OT, while my 2 colleagues on the right will be demonstrating a session for CT. So in terms of environment, we found that OT was held in patient rooms, the OT gym, and the ADL department of Loma Linda East Campus. CT was also held in patient rooms, but with a bedside computer therapy cart and also at the computer therapy lab. When it came to goals, we found that CT focused mainly on ADLs, while traditional OT included IADL related goals in addition to just ADLs. Both types of therapy address very similar performance skills, but the main difference is that OT consisted of a little more motor performance skill training, while CT had more visual skill training. This can be seen in the ways each therapy worked on coordination, range of motion, and strengthening. OT was comprised of more gross motor movements like ambulating, improving standing endurance, muscle strengthening, and walking on different terrains. CT obviously involved more sitting, so the activities were more focused on the upper extremity movement and visual processing activities. In terms of support, OT saw more tactile cues like contact guard and hand-over-hand assist, and involved minimal adaptive equipment other than the quad cane. CT involved more task modifications for grading purposes, and utilized more adaptive equipment than OT, such as a mobile arm support, wheelchair, and touchscreens. Our findings here demonstrate the total change in functionality in GG scores as related to age and number of CT sessions. The bars colored in orange represent our younger age group, while those in blue represent our older age group. We can see a higher level of change in GG score shown in the younger age group in comparison to the older age group. Now, this may demonstrate how younger patients have a greater recovery rate due to the help of youth on their side, or it can simply show that they have greater affinity to the use of technology for therapy in contrast to that of an older patient. The exact reason why is confounded by variables, so further research should be conducted before any major conclusions regarding age significance can be made. But what is for certain is that regardless of age group, with the greater number of CT sessions, the greater the change in GG score, conveying a greater level of improved function.
Overall, we found that there is no added value in including CT or computer-based therapy over OT, as there was no significant difference in GG scores between both groups. Within both groups, we found that GG scores had improved from admission to discharge. Group 1, or traditional OT, and Group 2, OT and CT, both had significant changes in GG scores in all domains of ADLs. Identifying these 2 treatments to be effective in traumatic brain injury rehabilitation. Both groups showing significant changes in GG scoring in all domains also suggest that the addition of CT did not contribute to a greater functional gain among TBI patients. Group 1 interventions focused on ADLs, strengthening, and coordination, and Group 2 interventions focused primarily on upper extremity strengthening and endurance, with the addition of high repetitions reported. We found that a greater amount of CT sessions indicates a greater change in GG score overall, as well as younger patients showing a greater change in GG score when compared to older patients. Within our study, CT was used as a replacement for some OT sessions, which resulted in a decreased number of overall OT sessions for Group 2. CT is meant to be used as an adjunct with OT, not replacing OT sessions. So future research may benefit if both groups of participants experience an equal number of OT sessions, with the CT group receiving CT in addition to OT. In conclusion, our research revealed that there was not a greater change in functional scores when computer-based therapy was used as a replacement for some traditional OT sessions. The study supports the role of OT and CT for traumatic brain injury, as both improve GG scores for traumatic brain injury survivors. Further research is required to investigate the benefits of CT as an adjunct to OT in a variety of populations. And so, using computer therapy and occupational therapy together is like a power duo that combines the best of digital innovation and real-world skills to help our patients conquer obstacles and level up in life. Thank you very much.